So I'm glad you made that point about that piece on the slide about being touched kindly. There was I was at a birth in the Democratic Republic of Congo in Bukavu, and it was a fairly short labor, but it was so, I had seen lots of births in very low resource settings, but it was so violent, it was so extreme. I felt physically shaken. I had been at the woman's right shoulder, and the group was mocking me. The group of healthcare providers that were in the room actively abusing the woman were sort of mocking me because I found it very difficult to keep my provider face on in that moment because it was so extreme. And it was over very quickly, and it was the first time I'd seen a birth in Congo. And a few minutes later, I got to do what I had arrived to do, which was to have a short interview with the midwife who I had just watched perpetrate this abuse. And I asked her, tell me about why you do your work. And I could still feel my belly just reacting to what I had just seen and heard. And she went on to describe her love and commitment for the women and children in her community with such absolute sincerity. And that dichotomy, those two things happening at the same time, I believed every word she said, but I also had seen some of the behaviors that were normative. And so I hope that we talk a little bit today about how do we not demonize the frontline providers who we know are part of an oppressive system. And move towards solutions. So thank you for pointing that out. So we have some time for questions, and I know this can be a topic. So Dr. I'm going to start in the back because I saw your hand first, and we'll collect some questions and then give it to our panelists. So how about we go like this to the front and then to the side. I'm sorry, I'm not as good with everybody's names, but okay, and then we'll come back to Tom. All right, we're going to do a snake. So why don't you start, Dr. Gore, and then we'll...
Good morning. It was very enriching to hear all the speakers and look at the respectful maternity care from different perspectives. And I think it's very important that we keep on talking about it because we know that everything is not right and we want to really change it and have sensitive providers there. Having said that, I just want to draw attention of the House to one fact that talking about RMC and looking only at the recipient side, I think it's not quite right. We really have to look at the root cause of why the respectful care is not happening. The HRH, we know that across the globe, there is a crunch, and people are working in different situations in very limited resources. So unless we hit that root cause, that why people are so demotivated, frustrated, that they are very, very normal to bring that frustration on to their clients. I think that is very, very important to look at. And unless we go to that root cause, the expected respectful care to the providers is not possible. Like I was just thinking that we are so much talking about different positions of delivery. So if I have an opportunity, because I have a big nurse mentoring program in Bihar. So if I feel that, if I think that I can change something, I have a good opportunity. But my problem is that if I want to give people in the facility a choice of a squatting position, my basic problem is where do I train my nurse mentors so that they are skilled to conduct the delivery in squatting position. I'm at loss, and I look for help from this House if they can tell us. So that is one thing. And also a small point that while we are talking about respectful care to the clients, I think we also, let's not go too far in saying that, because, you know, I just want to bring one example that, you know, induction in 40 weeks is a medical indication. It's post-maturity that, so I totally agree that induction because of the provider's reason should not happen, but there are some medical indications where we'll have to have that protocol in place. And that's what we are saying, that's why the protocols are there, that we stick to the protocols and we have some standards of quality of care. Thank you.
I love getting into some of the nitty-gritty of this, because only this audience with this much experience can do it. I think
Thank you very much for your excellent presentations. I'm Kasturi Sen, and I've been working for OPM in Bihar for the last few months, but previous to that for the last 2.5 decades in several states of India on access to healthcare. I just want to make a few observations because it was a really interesting group presentation there. I think the first one is to say that this notion of humiliation of women by the state is clearly a global phenomenon, and it's an ongoing one. But I think in India, it's really important to note, and possibly in other states here, caste and class are key factors in that. So if you're of a low caste or of a minority religion, you're at much greater risk of being abused. So that's really important. Middle-class women would be much more protected than the lower castes and minority religions. And I think the second point I wanted to make was that I'm based in the UK, although I'm from Bengal, is that until about 25 years ago, in the National Health Service, nurses and midwives were regularly shouting at women in the labor room. And doctors were shouting at midwives, and midwives were shouting at women in the labor rooms. And I think this was challenged by patients groups, and particularly the Maternity Alliance, which started lobbying over about 25 years ago and brought in patient perspectives, and this started shifting. And and still now, I think migrant women and asylum groups and refugees still face abuse in Britain. But I think it's the lobbying, and I'm just wondering if you could say whether the Rogi Kalyan Samitis in some states in India, and I think they're available everywhere, who could act as patient advocates and be part of this changing scenario. And I know that certainly in West Bengal, this has happened. I mean, when we did our work in West Bengal 20 years ago on access to healthcare, women were saying that they were regularly abused in the public sector, that they waited several hours to see the doctor, and then the doctor wouldn't look up, and then he would give them with a few seconds, and often shouted at them. So then we asked the provider, why did you do that? And then they said, we have 300 patients to look at between 8 and 11. We don't have paper, we don't have electricity, and the conditions are awful. So the facility issues are absolutely key, which you brought up also. So it's a combination of different things. Thank you.
Maybe we can pass it off. I think Dr. Sen, did you have a question? And then, and then we'll snake back around, okay?
Thanks, and thank you all for really great presentations, and Lynn for your really perceptive comments. I want to just focus on one aspect which sort of has come back and forth, and which I think got picked up as well by the question. It's very clear that one of the drivers is the kind of pressure on resources, time, equipment, conditions of the infrastructure, all sorts of things that do pressure providers in terms of this. The question is, well, there are two questions that are really important here, I think. One is, so what is our responsibility as adults, adult human beings, when we are in situations of pressure? Accepting, and it's very important for us to understand the nature of the pressures that are at work on providers. This is not an excuse we would give if it came to the husband who is slogging all day on a construction work site and then comes back and beats up his wife. We would never give that as acceptable because the poor guy is under X, Y, and Z pressure. Yes, he is under X, Y, and Z pressure. So is his wife. So are the kids. So is everybody around in the community. The point is, these kinds of pressures are a fact of life. And I think it's very important in our understanding of drivers that we not then use that as a way of diminishing the responsibility of people. And I think it's entirely possible, as you were saying, in terms of the NHS or everything else, to say, yes, we understand that. That doesn't give you the right to do X, Y, and Z. But I think in that X, Y, and Z, we need to understand that it actually consists of two kinds of things. One is the hitting, slapping, verbal abuse, pinching, what have you, etc. The other is the fact that exactly those kinds of pressures on resources lead to actually changes in practices, like the routine episiotomies. The routine episiotomies aren't done for the reason of being disrespectful. They're done in order to speed up the process. And I think we do need to distinguish between these. And I just have a question for Shalini in terms of the ICMR study. Could you comment on what you're finding in the study in terms specifically of this set of questions? You said people weren't, they said, wow, we never learned about any of this. Just give us a sense of what you're finding from the study on this.
So we're going to move on. I think it's Brenda in the back on the edge. She raised her hand early. And then if I can just say as we go through, we've got Brenda, Tanmay, Leila, Dillis, and Punu, I think. Punu, excuse me. So, and then we'll have to stop. I'm sorry. So if you can just keep it brief so we can give the folks the last comments here. All right, go ahead.
I just wanted to say that, the focus on RMC will, I hope, allow us to really start looking at the woman holistically and not just at that particular moment, like a case of PPH or a case of, prolonged labor. And then it will allow us to see what are her future needs, not just the overt need, but the covert needs, which means like a woman who's come, who's anemic, if we are able to look at the fact that she needs postpartum family planning, which will help her to give her the time and allow the other interventions to help her to get out of that anemic status. Otherwise, they just get into a vicious cycle of high-risk pregnancy becoming another high-risk pregnancy because of early, conception postpartum. So I just wanted to highlight this concern. Thank you.
And then Tanmay, go quickly, and then we'll go to Leila.
As always, I have a measurement question. First to Dr. Karima. You spoke about having a kind of open-ended last part where we can actually get the experience of the enumerator to understand more things which are falling into the groove. Do you suggest that those will have an opportunity of having some post-coding to translate them into some of the quantitative aspects, or you want them to be analyzed just qualitatively? And another question I have to all of you. There was a systematic review discussion that happened in our last RMC meet where we met. And based on that, we conducted a detailed systematic review. And we found that wherever there is the experience of the women being assessed, the expectation is largely missing. That is ending up into something like when we analyzed what is happening caste-wise, the respectful maternity care aspiration regarding women and all those stuff, we are finding no changes because probably expectation is also low there. So how to factor that in? Because largely globally in most of the studies, what is the expectation and after that what is the experience, that particular piece is missing. So some suggestion regarding that. Thank you.
I think I'd like to raise a question for the panel. We're talking about India, and we're talking about respectful care, quality in India. I know many of you sitting on the dais enjoy wearing Indian fabric, and you know the difference between quality of a product, a good pallu, a good sari versus something that's mass-produced. This is the same country which understands that quality, and that quality does come from the villages. These wonderful fabrics that we wear do come from this culture. So what is good quality which is understood locally
by women in their culture. Have we ever experienced or tried to understand what good quality midwifery was and should be? And I'm trying to hark back to historical traditions within India of midwifery. Thank you.
I'll be very, very quick. One thing that is just sticking with me from the presentation from Kaveri is that artist's rendition of the delivery and some scary stuff going on there, blood and a big clamp and everything. And if you looked at where each of those 5 nurses' eyes were dead on the patient, and I think for me, that perspective gives everyone in this room, or me, a lot of hope, because she has seen all of it, and she decided that all the women would be looking right at the patient. So I thought that was extremely powerful. So very, very briefly, I'm sitting here wondering about the whole issue of comparing the middles, and not everybody in every facility is treated badly, and we need to know what the drivers of those are in the middle to better address it. When in the presentation that 23% were reporting something about respect, and then only 1% cared about privacy and 2% cared about this or the other thing, I'm curious whether you think we're asking that question correctly, because I was shocked that those figures weren't 50, 60, 70%. So what do women want that here in this context we're not asking correctly? And finally, when this whole issue of yelling in the delivery room and in an emergency situation, I have heard providers talk to each other that they felt the care was poor because the providers, in a simulation I'm talking about, were not yelling. And that yelling would, from the patient's perspective, indicate high quality care. And only when we then asked the patient actress, how did it feel having people yelling around you when you were bleeding and your baby wasn't breathing, did they all start to reflect that, oh, maybe that's not what they want to hear.
Thank you. I'm sorry, we really want to make sure these folks, so Punu was the last.
There's some hands that came up later. I just want to say that we really have to wrap up at 11. Let's use the tea time as a way to have these conversations. Poonam, and then we're going to just go to the panel.
So I'm Poonam Mutreja from the Population Foundation of India. Can't make a stronger case than Geeta Sen for no excuse reason for treating women with indignity or lack of dignity. I just want to highlight 2 areas which we could use, 2 opportunities which we could use for this new, very welcome from the panel and others to look at women's dignity and rights as a key right, quality as well as rights-based issue. And I'd like to remind us of the Justice Lukur Supreme Court judgment, which is based on the tragic deaths, tragic as it may have been in Bilaspur, as it was, not may have been, sorry, where 16 women died in a sterilization camp, and many people raised it. Amongst them, PFI did a report called Robbed of Choice, Dignity, Indian Women Dead After Mass Sterilization, and Justice Lukur, fortunately, did use our report in the Devika Biswas versus Union of India case, where Justice Lukur brings out Article 16, and while he didn't use, we were very sad, he didn't use the title of our report and didn't use the word dignity anyway, but it was clear, internalized it, and if you look at what he says under Article 16 as a reproductive and sexual right, I think we can use that a fair amount for monitoring and for introducing within the government's public health system, because when we went and shared the report with the ministry, they acknowledged that everything we had said and everything the Justice Lukur Committee said was wrong with the system, and a letter was sent out by the Additional Secretary Health, then Secretary Health in 2016, listing 10 points which need to be changed in the public health system on quality of care, and it wasn't just about family planning, he broadened it. So I just wanted to flag that and see how we can use it.
Okay, so I am going to allow one more question just because it's a voice we haven't heard. Can I ask you to just say your comment very quickly? Sorry. Okay, you had a comment very early, and I'm sorry I missed you, but briefly, and then we'll
Yes.
have 2 minutes each.
Yes. My one question is about from ethics point of view. I represent several ethics committee and I'm from a research organization. So how do you deal with direct observation of childbirth from ethics point of view? That's my first question. And second question is, do we really now have to think of respectful care instead of just respectful maternity care? Thank you.
Oh, so lovely. Thank you. Great. All right. So I'm pitching here 2 minutes each, and maybe we'll start maybe at the far end and work our way back to Dr. Friedman, our discussant. So do you want to start, Dr. Sim? Is that okay?
So I think Dr. Sen posed a direct question to me, so I'll answer you first. So the findings from ICMR study, the studies just started in Jan. So we don't have the findings as yet, but what I shared was the findings from the national workshop feedback. That's what the providers had to say, that, you know, we didn't realize that, yeah, this is disrespect, and, you know, what is respect and what is disrespect. So one is from what we are looking at in these studies, what do the providers feel, you know, from their point of view. We're not looking at the women's point of view yet, because that part, I think, quite a lot, Aparajita and her team, they are doing it. So we are strictly looking from the point of view of the providers. I mean, do they know what they're doing is not correct? And because the interventions will emerge from that. Because once they know that this is not correct, they only will suggest how to improve that or how to intervene. So that's the whole idea of our study.
Thank you, Geeta and Lynn, for saying it much better than at least I could have said. And I agree that whatever observations we have done, it tells us that A, you're a woman, B, you're poor, C, you're uneducated, D, you're a migrant. And if you come with all of this, your chances of disrespect and abuse actually goes completely up. In one of the northern states where we did observational studies, the same provider, same labor room treated the local women differently than the women who migrate to that state to work in brick kilns. Same, like, you know, women lying next to each other. So yes, you know, this is, and added to that is this really low expectation and acceptance if you're poor or if you belong to a lower caste. So I mean, that's a big problem, and I don't think we have the answers of how to deal with that. The second thing is, yes, there have been different comments about, you know, creating an enabling environment for the provider, whether it's stress or infrastructure or HR, but I don't think we have talked enough also about redressal and accountability. I think, you know, what redressal does the woman have? I mean, we have seen women being stabbed with scissors, iron rings in between the legs, all sorts. We don't want to share some of that, but, you know, what is her redressal? Even the ashas have come to us saying, I don't know where to go, what to do. So I don't think in our context we've talked enough of that. Accountability, in one of the recent state government meetings where maybe there were just 2 people who didn't belong to the medical fraternity and practicing doctors, and Government of India has introduced birth companion, and there were about 75% of them standing up and saying, it's not possible, it's crowded, give us birthing suites and we'll give you birth companions. And there was another group who challenged them saying, why don't you want a birth companion? Because you can't slap her if somebody from a family is there. So I think these are things, you know, organically happening, and I think we should be supportive. And the last point you asked about, you know, what kind of questions we asked, we actually asked just one question: what is your top priority quality ask? It's only when women responded, we got the postcards that we went and analyzed at where did the ask fall into. And I'm going to take the moment also to say that this campaign that we did last year is now a global campaign, and tomorrow the campaign, the What Women Want 1 Million Voice campaign, will be launched tomorrow. And I want all of you, whenever you have time, to go to the website whatwomenwant.org, and please, we want your wants too. Thank you.
I just want to say that, you know, we've talked about women's identities and their vulnerability to DNAs, disrespect and abuse, or or lack of respect in maternity care. I just want to flag the question of intersectionality in quality, especially because pregnancy is not an illness, and there is, an element of agency and voice that a woman has, and that is what is being constantly negotiated. The other point linked to that and linked to the question of low expectations is, yes, of course, expectations are extremely low, and that partly comes from very adverse histories with state institutions, but also a fact that, a lot of women are at sea in institutions. They haven't gone through a secular shift in terms of their own preferences for delivery. I mean, lots of deliveries take place at home, but these women are now being, shifted to institutions without any preparedness. And so I think linked to what Yerka was saying yesterday is that we do need to have, movements and efforts to raise people's expectations, women's expectations about what they can expect and what their rights are in institutions.
Tanmay, I'll answer your question first because I think it was directed directly at me. My understanding, and correct me if I'm wrong, Nicole, but I think what Kaveri was planning is just to do a qualitative thematic analysis of the comments. Is that correct?
I think that's where I think Kaveri may leave it, but I think this work was another important reminder of that formative work that needs to inform quantitative instruments. And we've had this model in other places. It's certainly due here now, and it's going to look different in Bihar than it does in other states. So I think to your point, it's absolutely essential. Originally the data wasn't collected with that intent, but it certainly made that need very clear. And hopefully that work will happen. Obviously lots of folks here who would like to see that happen. So we have good tools, good measures.
The other comment I would just like to make is speaking to what Dr. Sen raised. I mean, I firmly believe there's absolutely no excuse for the kind of disrespectful care that I personally, for example, have witnessed in Egypt, and that is clearly also, happening to a great extent in India. Having said that, I also believe that we do need to look at, providers' circumstances, et cetera. And yesterday we talked so much about context and of talking to providers, understanding what they need and supporting them, and et cetera, et cetera, et cetera. However, I don't know why. I really wish somebody would answer this question: why communication skills and respectful care and how to speak to a woman properly is not really emphasized in medical school. I mean, nobody taught me one word of how to talk to a patient, let alone how to talk to a patient when she's in labor, et cetera. And this is completely absent from medical curricula, of course, all across the Middle East, and I realize it's also to a large extent absent here. Why is that not a thing? And of course, providers learn, blame high stressful situations and say, well, we have to do it. We have, 1,000 patients and this many deliveries a day, et cetera. But then because these behaviors become so normalized, then they become routine practice when they're not in a high stressful situation. So as long as they're not in their private practice and trying to encourage women to come back, as long as they're still in a public facility, even if they're doing 1 delivery a day, the not very nice care has become the norm, and that's just sort of routinely applied. So, yeah.
Thanks. I think it's possible for expectations to change and for norms to change. And one of the things we haven't had the chance to talk about yet is what principles we should be using for thinking about interventions. And just open question whether there are new, more creative ways to develop interventions. Human-centered design is the obvious one that comes to mind, that are also part of the process of people changing their own expectations and norms. And I think we should be thinking about how to engage people in a different sort of process to change their own situation. The engine of change is from the ground, and I think we have to figure out how to ignite that.
Any other final comments from the panel? Here, Sunita, did you want to add anything? What about your? Oh my gosh. The measurement, the elephant in the room of measurement is hard to ignore, and so that pains me it would be a waste to see some of that qualitative data and not be used, certainly. One of the things that I wanted you to know about, in addition to the What Women Want campaign going global, also a multi-country effort on behalf of USAID, which is but one organization, I understand that, but they did just recently publish Respectful Maternity Care Operational Guidance, which is designed to help support local, flexible development of interventions to address RMC. And so while no tool is perfect, if you combine that with the RMC toolkit that's available online already, this operational guidance that was just published, in the last 4 weeks maybe it came out, easy to download PDF, this will provide some starting point for organizations that are trying to get their heads around this issue and what solutions might look like in that setting. So I can't repeat it more, that local context matters, but what I hear here is the importance of that interprofessional approach, change from the ground up, certainly, and really thinking about what those local solutions might look like. So anything else? Yeah, thank you so much. I feel like that was a bit hectic, but it's a charged topic, so thank you for your patience. And if you didn't speak, I don't know, you don't find me later, I'm sorry.
So we have these 3 working groups in the afternoon, and if people desire, we can have a smaller working group around this topic, because I think it's really important. So if you didn't have a chance to speak then, perhaps we can do that in a smaller working group around respectful care. So. A break for 10 minutes, and then we'll reconvene. Our research partners on the ground have been doing on quality of public and private services, family planning services in UP and Bihar. This is actually a consortium presentation on behalf of 4 organizations that have been working on the ground over the last 2 years. Sambodhi, OPM, Population Council, and ICRW. And what we have is, over the last year, Sunita and I have been working with all of these different research partners, because there were studies in UP and Bihar, to put it all within one common framework with common kind of aligning the measures and the data, and try and derive insights at a very collective level, some comparative analysis between UP and Bihar as well. And we'll start with that presentation. So it's just a presentation to ground the discussion that we're going to have following that, which is not only limited to the data in this presentation, but the context since that time has changed. When these studies were done, we really located them to understand quality of care issues within 2 methods, IUCDs and sterilization, because really that was what we had a couple of years ago in our public health system. Since then, in the current context of the Mission Parivar Vikas, as some of you or maybe all of you know, we now have begun the rollout of injectables. And so we actually have a new method with new demands on what it means to be able to give the, adequate information, choice, and counseling to women. It is a repeat touch method, so we need to have much more interaction on a systematic basis with women. And so given what we find in our quality of care studies, what does this mean when we are now introducing new methods? What does it mean? What is the kind of stress it will put in our health system? And also just building off the discussions we've been having the last 2 days around disrespect, equity, rights. So the panel is really going to be talking about how do we create a much more rights and choice affirming approach to provision of family planning. So we're going to start with the presentation. So on behalf of the consortium, we actually have Arnab, who also presented yesterday in the lightning talk, to present the data. Arnab, you did hear his introduction yesterday, so I'll be briefer today. He's the Assistant Vice President at Sambodhi, and he manages a research portfolio. and provide strategic support in conceptualizing various MLE assignments. And with that, I'm going to ask Arnab to get started. And Arnab, you can acknowledge your colleagues later, because there are many of them.
Thanks, Priya. So as Priya was mentioning, I'm going to talk about findings emerging from a collection of studies done in UP and Bihar. The studies were essentially done between December 2016 and February 2017. That's when the data collection happened. And as Priya was mentioning, this was essentially an effort of a lot of different organizations, ICRW, IP Global, OPM, Sambodhi, and Pop Council. I really will be calling out to all the members of these organizations to talk about relevant points during the discussions. I would also like to acknowledge a big thanks to colleagues at the UP and Bihar TSUs for their constant encouragement and support in making this study possible. So without further ado, I'll get into the conceptual framework that we utilized for developing this framework and to really analyze all of these different data sources at a common platform. And what we did really was to use the Bruce and Jane framework that we discussed about yesterday and situate it within the rights and empowerment framework. And we are really looking at three different buckets. The first bucket that we talk about is facility readiness, both in terms of basic infrastructure from a client's perspective, readiness of facilities in terms of delivering clinical and non-clinical methods, as well as readiness of facilities to provide infection prevention services. In combination to facility readiness, the second bucket is really about providers' skills and knowledge, which looks at both doctors and staff nurses together. And the key hypothesis here is that when a facility is ready and when providers are sufficiently skilled, they have knowledge and sufficiently motivated, that would lead to better practices, which brings us to the third box really, which talks about provision of method choice, provision of information to clients, as well as adherence to clinical protocols, which we were able to observe directly for sterilization and IOD procedures. And the final outcome that we are looking at here is a method and service satisfaction from the clients, a reduction in number of complications, thereby leading to sort of an increased MCPR, increased continuation, and so on. So this is really the framework that we adopted from the Bruce Gen framework, and this is what we based all our analysis on. I would also like to highlight the different types of studies that went into it. The whole idea was to establish a really comprehensive idea of quality of care around family planning. It started with a facility audit to understand what kind of facility readiness we are talking about, a provider interview to assess their knowledge, skills, and then there were direct observations of procedures, as I mentioned, around IUDs, PPIOCDs, and sterilizations as well. All of these interviews were sort of followed by exit interviews of clients who came in for counseling or to get certain services. In addition, there was a follow-up interview of clients after 3 weeks, after 4 weeks, after 6 weeks, which looked at continuation rates, complications, and so on. I'm not going to get into the sample sizes, but there were about 437 odd facilities that were being captured across the public and private sectors in UP and Bihar. Apart from this, we also conducted interviews and observations in clinical outreach teams, something that was happening in UP and Bihar, but we are not presenting the data in this particular presentation. There is really a lot of data to share, and what we have done is to really pick out certain key elements from the huge slide deck that we had, and that focuses on key messages that we wanted to bring to the table today. That would also sort of feed into the panel discussions that's following later on. So I'll start with facility readiness. I think we looked at different dimensions as I was talking about. So basic infrastructure, readiness around infection prevention, readiness of facilities to provide sterilization and IOD services. And what we observe here is that while most of the readiness components were quite high, simple facilities like availability for functional toilet, which was defined as having soap and water and a door that could be locked from inside for women, was really low. In addition to that, there were a really low proportion of facilities which had specific staff that was trained on IP, and by specific staff we mean that providers who were responsible for sterilization. We found that those staffs were not trained around IP. This was especially for the case of Bihar public facilities, and this is highlighted here. The numbers are a bit off. So what we see here is providers who are sterilizing equipment trained on infection prevention was extremely low. I think it was something around 17% for Bihar public health facilities. And a combination of all these items essentially brought down the entire facility readiness around infection prevention quite substantially. And what we tried to do after this, we tried to look at facility readiness in terms of practices, and which gave us like really interesting results. So the 4 critical components of facility readiness that we sort of finalized on was a facility to scrub hands, availability of gloves, availability of sterilized equipment, and antiseptic lotions. So a combination of these facilities, and this is an example from UP, only 50% of those facilities had all of these components available around infection prevention. But when this was looked in terms of provider practices, of those 50%, only 50% of them were actually practicing those, so which essentially highlights that there's a weak correlation between a facility being ready and providers actually practicing infection prevention. We'll quickly move to method of choice and method information. The first graph really talks about method choice, and there are 3 components that we considered for that. First is whether clients were actually asked about their method preference, whether clients received method of choice, and whether they reported that they did not feel any pressure to accept a method. And a combination of all 3 of these things essentially tells us that, again, in Bihar public facilities, I think method of choice was really low, whereas in UP public and UP private it was hovering around 50%, clearly not where we would want to be. Method information index essentially talked about clients being informed about other FP methods apart from the methods that they came in, that was preferred by them, informed about the side effect of the method of choice, and informed about what to do in case they experience any problems with the method. And again, I think a combination of these 3 essentially tells us that about only a third of the women in Bihar public and UP private are actually getting all of these 3 information. And then we looked at factors of information exchange, whether clients were reported that fertility intention was discussed by the provider, whether clients reported that provider explained how to use the selected method, or if the clients knew or mentioned at least 2 side effects about the method that they preferred. So what we found that though the first 2 items had quite a high value, I think clients reporting their knowledge around the side effects of the method of choice was really low. This is a really interesting slide. We tried to look at provider norms, and we really asked them about the eligibility criteria of clients to receive certain methods of choice, of their choice. And what we found that the provider norms around eligibility was quite high actually. So a lot of providers reported that there is a method restriction around age, there's a method restriction around parity, there's a method restriction around the marital status, and also there is a method restriction around the husband's consent before a client can actually uptake that method. These numbers were quite high in case of private facilities in UP, which was a bit surprising to us as well. And I would encourage us to deliberate that in the discussions when we talk about it in more detail. Similarly, we have provided norms around female sterilization, IUD, and also I think Priya was mentioning about the rollout of injectables, and we do have some provider norms coming in from UP private facilities, which also talked about method restriction around age parity, husband's consent, and marital status, which were actually quite high. Then I'm going to talk about a different approach that we sort of adopted, and this is really the data from Bihar public health facilities, and Ruhi can talk about it in more detail. But what we did was to understand the quality of counseling that clients received. We used a mystery client approach in addition to the exit interviews that we were conducting, to understand what's the discordance between what clients report at exit interviews versus what kind of information do we get when we send in mystery clients. And the results therein are really quite interesting. The first one essentially talks about clients who reported that 2 or more methods were discussed when they went in for counseling. In this particular graph, we see that the mystery clients reported a higher proportion of them being told about or being discussed 2 or more methods, whereas for the rest of the items, in terms of no pressure, treated client with respect, or asked client whether she has any questions or not, the numbers are actually flipping apart from the clients, whether the clients had any questions or not. And I think this leads us to two important points. One was that the fact that mystery clients actually received more number of methods might be because of the fact that exit client interviews essentially were conducted with clients who had a preferred method of choice before coming into the facilities. And that may be a reason that clients or providers do not sort of discuss a lot of methods with them. Whereas in the other items, for example, client treated with respect, I think it's the benchmark that we are talking about. The benchmark of clients in terms of respectful care might be really low. Whereas the mystery clients who were essentially surveyors were attuned to the fact that of concepts around respect, of concepts around pressure during counseling, and so on. This brings me, I think, to the last data point that I want to talk about, and we tried to measure respectful care, and we tried to pull in data from different sources. These are really items which were common between the 3 different surveys that we are talking about, between Bihar public, UP public, and UP private. We could not develop really robust measures for respectful care around family planning. These items do not hang together well when we look at multicollinearity. However, I think there are quite a few interesting ideas here. So, for example, if we look at the next item, I think clients informed about test and examination results were really low in all kinds of public health facilities. Clients reported being encouraged to ask questions was somehow surprisingly high in UP public, but was very low in Bihar public and UP private settings. Whereas the rest of the reported measures or reported items were really high across all the 3 different geographies. With these data points, I think I'm going to talk about a bit about the challenges in measurement that we faced. The first really crucial challenge in measuring quality of care was really around getting sufficient samples, both in UP and Bihar, for female sterilization as well as IUDs. In UP, for example, I can talk about, so we do have fixed days on which a particular facility provides sterilization and IUD services. However, what we found was in these specific days, sterilization was the one that was focused quite strongly. I mean, we have anecdotes of cases when women came to those days asking for IUD services, and they were refused because that day was specifically meant for sterilization. So that's one. Second was that these these specific days were cancelled quite a bit. Just because of the unavailability of surgeons to make it to that particular facility on that particular day. In terms of observation of FP counseling, I think what we found was the availability of designated counselors was really low, and in most of the cases, it were the staff nurses, ANMs, and sometimes doctors who were stepping into the shoes of counselors. I remember talking to Vandana yesterday, and she was saying that in Bihar, it's actually something around 20 to 25% of facilities which really have a designated family planning counselor. Which brings us to a discussion around whether standardized patient methods like mystery clients is a good way to ensure robust estimates, and what do they really tell us when we specifically look at the discordance between what exit interviews told us and what the mystery clients reported. The last 2 points were really about aligning of methods and measures. I mean, we tried to do a comprehensive measurement where we can talk about what's happening in UP, what's happening in Bihar, what's happening in public, what's happening in private. But linking all of these data together was a real challenge. Even within the geographies or within the settings of UP and Bihar, I think linking facility to provider, to observation, to the client interview, to follow-up interviews was really challenging, and we do have quite a few insights on that. The second challenge, the second major challenge was to pool all of these data sets together. I mean, we had an exercise where we aligned all of these tools before going into the facilities, but you know, even aligning the method, even aligning at what time of the day that particular observation will happen, there were differences in that which we would like to sort of discuss and deliberate as well. And finally, I think a couple of key takeaways which I think can feed into the panel discussion that we're talking about. The first one is that facility readiness, even in terms of basic infrastructure from a client's point of view, is really low, as we saw in the availability of functional toilets. The second point is that ensuring a ready facility does not necessarily ensure practices. I think it's not a surprise, but then we now have empirical evidence to show that. In terms of clients being informed about their method of choice, I think the really challenge or the real bottleneck is around talking about side effects to client and what to do in case they face or experience any kind of side effect or problem after the uptake of a particular method, which leads to discontinuation. Finally, I think provider in provider norms, we saw that providers do apply restrictions in terms of eligibility of women who can uptake a particular method. The major restriction was really around husband's consent for sterilization, and we also saw that UP private facilities did have quite a significant proportion of providers who had very different norms in spite of no specific guidelines being there. And finally, I think another point was around the method of standardized mystery client approach, which talks about, and it really raises question on what kind of counselor interaction are we looking at. How do we sort of control the fact that clients actually come into a facility with a pre-decided method, and how do we sort of balance a mystery client approach vis-a-vis a client exit interview, and how do we finally tackle the low benchmark of quality among clients. Thank you.
Thank you so much, Arnab. And I also want to acknowledge the fact that there were like months of sitting together. Dr. Dinesh is here, really understanding what are clinical measures of quality and trying to reconcile that. And even then, whenever we've presented this data, especially when there are clinicians in the room, there still continues to be a debate. And the debate really is around, are these the right measures? If we say, these are the 10 essential aspects of equipment or drugs that should be there, then the debate is, oh, but this drug is replaceable, but this drug. And so, you know, there's always that debate around what is essential, non-negotiable items for any of these measures. And the second thing is, to what extent does clinical measure of quality match up with the measures we have around clients' experiences? And I think that debate has started in different ways since yesterday when we talk about respect, and how does respect validate technical aspects of quality. And this has been surfacing ever since we have started to look at this data and present it in different fora. So thank you, Arnab. I now will invite my panelists. I'm going to be a little briefer in the introductions, but because some of them have already spoken. So, Dr. Geeta Sen, she, as you know, is a distinguished professor and director of the Ramalingam Swamy Center for Equity and Social Determinants of Health, PHFI. So please, I'm going to be brief as... Yes, please come to the table, Poonam Mutreja, she's the executive director of the Population Foundation of India and has been working on women's rights, rural livelihoods, public advocacy, communication, and behavior change. I'm going to be brief, so just one line, because I want more time with the panelists. Please, Poonam. Preeti Anand, she's the project director for family planning with the UP TSU in Lucknow, where the focus of her work is to provide techno-managerial support. And prior to this, she's been working with MSI, DKT Bihar, and Aga Khan Foundation. Dr. Hemant Shah, who you heard yesterday, he is the Chief of Party Bihar TSP program. Dr. Ravi Verma is the Regional Director, Asia Regional Office of the International Center for Research on Women. Dr. Sanjeev Gaikwad is the country representative at APT Associates. And Chandra is, he's been working for decades on social marketing, and he is, your affiliation is not given, FR. Yes, I know, but sorry. So, in your bio. So, I'm sorry, it's a little crowded here, and just kind of find yourself a comfortable spot. So, as I said, this panel was designed to be kind of interactive and conversational, and we'll open it up. I'm going to start with Geeta. So, Geeta, based on the conversation since yesterday and what we've heard this morning, and particularly focusing on family planning, because since yesterday we've been mostly talking about maternity and maternal care, what is the role of providers in affirming choice and consent for women? Is there an inherent tension between the emphasis on technical quality and women-centered services? And in your view, what is the pragmatic and rights-affirming response?
That's all? That's all in 1 minute?
No,
5 minutes. Oh, okay. So I've already forgotten most of the questions, but so...
I want you to think about the provider's perspective.
Yeah.
From a provider's perspective, how do we think about a rights-affirming response for provision of care for women?
Okay. So can I give a little background before that, before I get into that? And I promise it will be only little. Just because it's been, 20 plus years since ICPD, and people have almost forgotten what that was all about. Just to highlight 2 or 3 things that are really important even today, 24 years almost since that. And I think these are absolutely important. The first was the big shift that took place from a focus on controlling numbers, which was all about population control, towards women's health and rights, specifically enshrined as sexual and reproductive health and rights. But really, that was the driver for the entire so-called paradigm shift. And I think we need to keep it in mind 22 years on, because we need to ask the question, what's the driver today? And the particular importance of that was that, and it was women who specifically said that with that driver, which is essentially around controlling numbers and population size, you're headed down the slippery slope of abuse, disrespect, and all kinds of other things, because you're primarily not thinking of women as human beings, you're thinking about them as baby-producing machines, women or men, as we know from our emergency male sterilization problem days. That was one. The second very important element of ICPD was that in doing this, it really broadened the idea of the right to health and what does the right to health include, who should be the duty bearers around the right to health. If one starts seriously looking at sexual and reproductive health and rights within the context of the right to health. So that it said that we need to look at what is available by way of services, infrastructure, clean water, sanitation, the toilets that Arnab spoke about, and so on. But we also are looking at such questions as decision-making, autonomy, bodily integrity, etc., and very importantly, freedom from violence. These three were the absolute non-negotiables of that paradigm change. Now, in the context of the 20th year review of ICPD that happened 3.5 years ago or so, there was a great deal of work done to say, where have we reached in 20 years in this context? And I think that there were three things that were highlighted as things on which we really needed to make much more forward movement. The first one, and there was a big UNFPA did a big global review of accomplishments and said that inequalities stand out hugely. Inequalities in terms of access, inequalities in terms of who is served, inequalities particularly in terms of younger adolescents and others and so on, and younger people, adolescents and others, and so on. So inequalities in terms of access, availability of care and services and so on was highlighted in that review as a big issue. A second big issue was, in fact, the quality issue. And the quality issue in this context was particularly looked at from the human rights angle, which is the AAAQ issue, meaning availability, access, acceptability, and quality. And it was looked at from that perspective. And the third one that was seen as really we were falling short was the accountability question. And that in as much as during, before, and for some of the time after ICPD, civil society organizations, particularly women's organizations, had played a huge role within India, within other countries, globally, in forcing accountability and saying, stop thinking about us as a number, as baby machines, that you need to start thinking about women as human beings, that was a very important element in that accountability question. But these were the three things that were highlighted in the 20th year review as still deeply problematic in terms of how we were moving forward. Now, the question we have here, I think, in the Indian context, is that we've had some forward movement, some backward movement. And given that when it comes to contraception and when it comes to family planning, we have both public and private providers involved, but that a lot of the emphasis has tended to be on the abuses within the public program and not enough on what is happening within the private sector. That is a first question that I think, in terms of looking at it from the provider's perspective, we really need to look at. And I'm really glad to see that in the consortium work you have both public and private providers. But I think that in terms of the challenge we have there, I still think that we're missing some elements of what were fundamental to the basic Bruce Jain framework. We're looking at new methods coming in, as you said, Priya, injectables coming in the country. One of the things that had been highlighted right from the time of ICPD was the question of regret. do women have the ability to reverse a decision? And which methods support that reversal of decision if they change their mind for whatever reason? They may change their mind because their circumstances change. They had 2 kids and they went along with the government propaganda and said, "Tu do bas," and then both kids died. For some reason, now they want another child. Are they able to reverse? It could happen because they don't like the method that they've been using. They find it problematic. They can't handle the side effects. They have problems with it. And this is particularly true for IUCDs, we know. Regret is a huge problem when it comes to sterilization. But for IUDs, certainly that's the case. What does it mean when you get something like injectables? It's not a, reversal in the sterilization sense is not a challenge for injectables. The woman will not appear again if she doesn't like what's going on. But in terms of you regret this method because you don't like what it's doing to your body, do you have a choice of something else? And what is that choice? And I think that that's a question that we really need to raise. How are the new methods different from the old on this touchstone of these 3 things: equality, quality, and accountability? And I think that we need to be looking at them much, much more closely from that perspective.
Great, thank you. That really sets the stage for the nature of conversation we want to have, especially as we get into the implementation space. So thank you so much, Geeta. And I think Poonam, obviously you'll pick up from where Geeta left, but